Hello and welcome to Talking About Tumors with Ryan and Ryan. I'm Ryan Holstead.
And I'm Ryan Quinn.
Before we get started, I just want to thank everyone who's been listening so far. And to those of you who have any feedback for us, please send us an email or tweet at us, as we appreciate any feedback and hope to continue making this a better and a useful tool and resource for all of you in your training.
So today we'll be talking about localized colon cancer, and we're really going to be going through the standard of care treatments and the evidence for adjuvant chemotherapy after surgery for localized colon cancer. We're not going to be discussing rectal cancer. That will be a separate talk on its own because it's really treated much differently.
When there's suspicion for a malignant disease, whether following a diagnostic biopsy or based upon symptoms, workup would include doing a colonoscopy, as well as a CT of the abdomen, as one of the highest sites of metastatic spread is to the liver, and it's important to rule this out before approaching the disease curatively. Chest imaging is part of the initial workup as well, although typically we use a CT scan for this. The guidelines state that chest x-ray can be acceptable.
So once you have a patient who was diagnosed with colon cancer, if it is determined to be localized, the first treatment is surgical resection.
For the sake of this being a medical oncology podcast, we won't go into the various surgical techniques that are available, but we'll mention that there are different approaches depending on the location and extent of the disease. Things that we should pay attention to when the patient arrives to us is, first off, did they have a preoperative CEA? This can serve as a quality measure, and for tumors that are elevated in CEA prior to the tumor resection, this may serve as a way to monitor for disease recurrence later on. If the CEA was not elevated in the first place, it's less likely that this will be a useful tool down the road.
And by elevated, I think it's a CEA greater than 5 that is typically the prognostic measure.
On the topic of CEAs, and this is going to be true for all of our tumor markers, there's non-cancerous reasons that tumor markers can be elevated. And for CEA, false positive causes can include any cause of GI inflammation, so gastritis, peptic ulcer disease, diabetes. In addition, COPD or smoking can raise CEA as well.
So when a patient comes to you in clinic after their surgery, probably one of the most important things you want to look at is the pathology report, as well as confirm on the imaging that there was no evidence of metastatic disease. Most of these patients will have adenocarcinoma. This is by far the most common type of colon cancer, but there are a few other types. For example, there's signet cell carcinoma, which generally confers a worse prognosis. There's also medullary, which tends to have a better prognosis, as well as mucinous, which there's not as much evidence on the prognosis in mucinous.
There's going to be certain aspects of the pathology report that are also going to play a prognostic role, and we'll get into those in a bit more detail when we move into management of stage 2 disease. Ultimately, when a patient is presenting to you in the medical oncology clinic, the question is going to be, is there a role for adjuvant chemotherapy? And first off, the data is mostly in support of management for stage 3 disease, so this is disease that has lymph node positivity. So when the surgeon resects the tumor, they're going to be sampling localized lymph nodes. If a single one of these are positive, becomes a stage 3 disease. One kind of unique situation, you may see that there's report of a tumor deposit in the serosa or mesentery, and this would be an N1C disease. So although not a positive lymph node, still higher risk and considered stage 3. If the tumor is lymph node negative, the characteristics that would make this a stage 2 if the invasion of the primary tumor is through the muscularis propria into the pericolorectal tissue.
Now, the staging for colon cancer is the typical T and M staging. Unlike some other cancers where T is significant for the size of the tumor, with colon cancer, the T is actually only determined on the pathology report. The T signifies the depth that the tumor invades into. T1 is into the submucosa, T2 is the muscularis propria, T3 is into the pericolonic tissues, and T4 would be invading through the pericolonic tissues into any adjacent organs.
And T4 is broken up into T4A for invading to the viscera, and T4B into an adjacent organ or structure. In general, the rule of thumb of invading through a tissue for higher T staging is going to be the case for any tumor that rises within a lumen. So when we talk about bladder cancer, which is within the lumen, colon cancer, which is within the lumen, versus our other tumors such as lung or breast cancer, where they're sit within a solid organ, where the size of the tumor is going to be more important.
So in general, the goal is to look at at least 12 lymph nodes when you're doing sampling. So when you're looking at the pathology report after the patient has surgery, it's important to make sure that the surgeon actually removed and examined the 12 lymph nodes were examined. If it's less than 12, then the staging can be a little bit tricky, and you're not exactly sure how many lymph nodes is actually involved with cancer because you didn't look at too many. So again, the goal is really more than 12.
One final practical consideration for these patients as you're looking through the pathology report is also to turn your attention to the operative report as well. As part of the surgical approach to these patients, surgeons will take a look at the mesentery and omentum, and this can be very helpful, as you may notice on the surgical report that they'll mention concern for nodularity or tumor deposits, and then you might have to go track down whether or not those are biopsied as well.
So the role of adjuvant chemotherapy in localized colon cancer is similar to the role of adjuvant chemo in other disease sites. The goal is really to eliminate micrometastatic disease that's present at the time of surgery. It's really to decrease the recurrence rate at the distant sites.
Because the disease is microscopic, there's no way of knowing whether or not it's there with our current tools for imaging, and our best way of approaching these are to risk stratify patients and administer the chemotherapy to those with the highest risk of disease.
In colon cancer, there's really limited role for adjuvant radiation. There's very small case series looking at this in patients with positive margins or perforation. We're not going to get into this on today's episode.
And that's in sharp contrast to rectal cancer, where radiation is a fundamental aspect of treatment. Looking into the actual chemotherapy side of things, the story in early colon cancer kind of mirrors the story in metastatic disease, which is to say the primary treatment was with 5-FU, and then later on the benefit of oxaliplatin was shown as well. Just before we get too deep into this, I will mention that both irinotecan, bevacizumab, and our EGFR inhibitors have been unable to show a benefit in the adjuvant management of colon cancer. The reason why FOLFIRI has been unable to show a benefit is unclear, really, and is one of those lingering questions in the management of this disease. Prior to incorporating chemotherapy into our management of colon cancer, stage 3 disease, which is to say node-positive disease, was characterized by a high risk of recurrence, up to 50%. The initial study to show overall survival benefits incorporating chemotherapy to prevent recurrence in stage 3 disease utilized a combination of 5-FU and levamisole compared to placebo alone. Also worth noting that levamisole is no longer used in this disease. In the study, the 3.5-year disease-free survival was significantly improved with a risk of 63% versus 47%, and the overall survival over that period of time was 70% versus 55%, giving us a relative risk reduction of 30% for recurrence or death.
You'll see in many of the adjuvant studies that we use this endpoint of 3.5-year disease-free survival. And this has been shown to be what we call surrogate endpoint for 5-year overall survival. So there was a large meta-analysis done with over 20,000 patients called the ACCENT meta-analysis that showed that patients who can achieve a 3.5-year disease-free survival are very likely to achieve a 5-year overall survival. So this is why this is often used as an endpoint in clinical trials.
And the benefit was proportional. This is in contrast to progression-free survival in the metastatic states. If we remember back to our studies that included bevacizumab, they were able to show progression-free survival, but not necessarily overall survival. For all studies that are using surrogate endpoints, it's important to know whether or not they've been validated in either clinical trials or meta-analyses.
Once oxaliplatin came into the fields of metastatic colon cancer, people started to wonder if oxaliplatin, in addition to 5-FU, can also give a benefit as we see in metastatic disease. And adjuvant FOLFOX was looked at in the MOSAIC trial, which was a pretty large study, had 2,200 patients. 60% of them were stage 3, 40% were stage 2. And this looked at adjuvant 5-FU and oxaliplatin in the, actually you should say this French word.
And this was compared to the Dugremont 5-FU and leucovorin, which is our basal bolus regimen. There was another study that also looked at 5-FU, leucovorin, oxaliplatin using a fully bolus regimen, FLOX. That was the NSABP CO7 trial, which also showed some benefit, but we won't go into that as FLOX is not commonly used anymore due to its toxicity. So the MOSAIC trial did show a disease-free survival and overall survival, and this held up to its 6-year follow-up analysis, where 5-year disease-free survival was increased from 67% with the 5-FU and leucovorin alone to 73% with the addition of oxaliplatin. There was an overall survival benefit seen in the stage 3 patients, with the 6-year overall survival increased from 70% up to 73%. The hazard ratios for this was 0.8, so roughly a 20% relative improvement in disease-free survival compared to 5-FU alone.
Now, talking about neuropathy, because that can be a significant side effect of oxaliplatin, and especially for patients in the curative setting where that you're expecting them to live years and years. So in this study, 13% of patients did have grade 3 neuropathy. However, after 2 years, only 0.7% had grade 3 neuropathy. So the vast majority of them, the neuropathy resolved after completing treatment.
Yeah, the only thing I would add to that is grade 3 neuropathy is quite severe. That's so bad that it's interfering with your ability to do day-to-day activities. There is a higher percent of patients that have grade 1 or 2 neuropathy, which isn't necessarily going to stop them from doing what they need to do, but can be a day-to-day nuisance. And I do caution patients that they may have some level of neuropathy that can persist. Another thing about the neuropathy, if you remember from our metastatic discussion, oxaliplatin neuropathy is typically cold-induced. There is a distinction between cold-induced and room temperature, and it is worthwhile asking patients if they're having neuropathy at room temperature. The room temperature neuropathy has a higher likelihood of becoming long-standing.
Now, we said in this trial that 60% of patients had stage 3 disease and 40% had stage 2 disease. Talking about the overall survival benefit, an important thing to note is that this benefit was actually only significant in patients with stage 3 disease. Patients with stage 2 disease had no improvement in overall survival with the addition of FOLFOX. So similarly with the metastatic setting, we can use the substitution of capecitabine instead of the 5-FU. So CAPOX, capecitabine oxaliplatin, has also been shown to be equivalent to FOLFOX in the adjuvant setting. So when you present the option to patients, you can present FOLFOX or CAPOX. So in terms of the timing of adjuvant chemotherapy, we typically allow patients to recover from surgery before starting the chemotherapy. It's very important. There haven't really been many randomized controlled trials looking at the timing of when you should start the chemotherapy after surgery. It's generally recommended to try to get the chemo in before 8 weeks after surgery, or within 8 weeks of surgery. Again, there's not really trials looking at this. Most of it is retrospective data, which could be biased because patients that had to wait longer than 8 weeks probably were more frail and had more problematic surgeries, which meant that they took longer to recover. So this could be why they did worse than patients who were treated within 8 weeks.
Certainly, if someone is medically recovered and a candidate for chemotherapy, I wouldn't delay any longer than necessary. But I wouldn't necessarily use a delay past 8 weeks as a reason to omit adjuvant chemotherapy. Potentially when someone's in that recovering from surgery mode, that's a good time to make sure you have all your T's crossed and I's dotted, such as placing your PICC line or port line, ensuring you have all the necessary blood work, and even booking for chemotherapy if you're in a center that might require a week or two to book in advance.
So getting into stage 2 disease, and this is again a little bit more controversial and many places practice this differently as the data is less convincing for stage 2 disease. Most of the evidence for this is in subgroups from combined trials such as the Mosaic trial that had both stage 3 and stage 2.
Yeah, the Mosaic trial at the time of follow-up, looking at the subgroup of stage 2 patients, found the disease-free survival at about 6 years was around 5%, with an overall survival of 86.9 versus 86.8 using FOLFOX versus 5-FU. The subgroup at the 6-year follow-up of Mosaic trial found an absolute difference of about 5% in disease-free survival for the stage 2 patients. The overall survival difference was only 86.9 versus 86.8 for FOLFOX versus 5-FU. There was at least one large randomized controlled trial dedicated to stage 2 colon cancer. It did end up including a few stage 3 patients, which was the Quasar trial. A drawback of this is it used 5-FU alone, so it was not in the oxaliplatin era. And this trial found a 5-year overall survival benefit of 84% versus 81.5%, giving us a hazard ratio of about 0.8. There's been some meta-analyses of the cumulative stage 2 patients in randomized trials, and they've also been unable to find this overall survival benefit. However, there have been some high-risk groups that have been identified within the stage 2 disease that have a higher risk of recurrence, and the higher risk of recurrence is thought to have a higher likelihood of benefiting from adjuvant chemotherapy.
So some of these high-risk patients are patients with T4 tumors, so tumors that are invading into adjacent organs or structures. Again, these patients have pretty poor prognosis and have a high recurrence rate. Some other things we look for are perforation or obstruction, so patients who present with obstructing tumors. Poorly differentiated tumors also have a higher risk of recurrence. Patients with perineural invasion or lymphovascular invasion, and patients with positive margins. And the last thing would be patients who have inadequate sampling of nodes. So as we said, the goal is to get at least 12 nodes. ASCO actually recommends 13 lymph nodes, but ESMO and NCCN are 12. If you don't have that many lymph nodes at the time of the surgery to look at, then this can also be considered a high risk for the simple fact that we don't know if any of the other lymph nodes would have been positive had they been removed and examined. If you look at the guidelines, ASCO, ESMO, and NCCN all have different definitions of what they consider high risk. Most of them include T4, perineural invasion, lymphovascular invasion, but they all have slight differences.
One other high-risk criteria, and I think it's at least one of the, I think it's the NCCN, is elevated preoperative CEA. Worth mentioning that not all high-risk features are created alike. T4 is by far and away the highest risk feature, and T4 N0 tumor pertains to worse prognosis than T3 N1. The low lymph node harvest is also quite a significant risk factor. Some of the limitations with poorly differentiated definitions or LVI and PNI is related to the fact that not all pathologists have a standardized approach to grading tumors, and you may have some pathologists call a tumor high grade, another intermediate grade.
As we said, these are prognostic factors giving a higher risk of recurrence. There's actually very few studies that look at the benefit of chemo in these patients, so we're kind of assuming or hoping that you'd get additional benefit with adjuvant chemotherapy in these higher risk groups, but there haven't really been many studies to actually show that this is the case.
The Mosaic trial tried to break this down, and when they looked at stage 2 patients, those with the at least one high-risk feature had an inkling of increased overall survival. The 6-year overall survival increased from 83.3% to 85%, but this was not statistically, they weren't able to look at this from a statistics standpoint because this was not a stratified risk factor.
Another thing to note about the Mosaic study is that it's looking at 5-FU and leucovorin versus FOLFOX. So there's no placebo arm, so it's not really answering the question that we sometimes ask ourselves is adjuvant chemotherapy necessary? This study is asking if FOLFOX is necessary. Something to think about when you're interpreting the results.
One final thing on these risk criteria is that they're cumulative. So someone who has more of these versus someone who has just one of these continues to increase your concern for this disease coming back and may make you more likely to reach for that chemotherapy. Somewhat more recently, the impact of MSI status or deficient MMR status has been found to be helpful for risk stratifying and selecting patients to receive adjuvant chemotherapy. The utility of this is limited to our stage 2 patients, but if you remember, patients who are MSI high are less likely to benefit from chemotherapy in the first place and tend to have less aggressive colon cancers to begin with. So a post-hoc analysis of MSI high tumors found a better overall prognosis and essentially null benefit of 5-FU-based chemotherapy. In fact, there was maybe a suspicion that survival is worse giving 5-FU-based systemic therapy to stage 2 patients who are deficient in MMR. It's uncertain if this lack of benefit is still relevant if it's a T4 perforated, poorly differentiated disease with less than 12 nodes harvested. Essentially, it's one more tool to add into your pocket to make this difficult decision on whether or not to go forward with chemotherapy a little bit easier.
There has been interest in genetic profiling, such as the oncotype. Unlike in breast cancer, where the oncotype recurrence score is very heavily relied upon and used to determine if adjuvant chemotherapy is needed. However, right now it's still in the research phase, and there's really no role for this in standard of care treatment.
The one other new emerging prognostic factor I'd also mention is BRAF status. So remember, those are more aggressive tumors, and there's some thought of incorporating that into our pathology for earlier stage disease, as a BRAF positive deficient MMR tumor is going to be more aggressive than a run-of-the-mill colon cancer without any molecular targets. Although this has not been a validated marker in clinical trial settings, I think it's important to keep in mind that the margins of benefit in stage 2 disease are narrow, and these should be patient-centered discussions where you provide the evidence, because for someone, 2% overall survival or 3% overall survival over 5 years is going to be something that they absolutely want to go through chemotherapy for. But this is not necessarily going to be the case for every patient you encounter in the clinic. One of the limitations of our randomized controlled trials are that the majority of patients who were enrolled in these were less than 70 or less than 65 years of age. There had been some thought for our older patients that they may be less likely to benefit from doublet chemotherapy. However, this thought has fallen out of favor more recently, and observational trials as well as seared analyses have found that patients who get FOLFOX do have better overall survival than those who receive 5-FU alone. Once again, this is retrospective data, so obviously the patients who are fit enough to receive FOLFOX are going to have better prognosis to begin with than those who are being elected for no chemotherapy or 5-FU alone. But I think the general consensus is that age should not be a cutoff for selecting your adjuvant chemotherapy, and you really have to look at the patient in front of you. It's important to keep in mind, however, that the majority of our survival benefit has been seen with the 5-FU versus placebo, whereas the oxaliplatin adds a significant but reduced benefit to our therapy. So if you have someone's frail or someone with baseline neuropathy, or you're concerned about the toxicities of oxaliplatin, you're still going to be giving them good improvements in reducing recurrence with your single agent 5-FU or capecitabine.
So as we said, typically we give adjuvant chemotherapy for 6 months, so either FOLFOX or CAPOX for 6 months. There has been a recent trial called the IDEA trial, looking at if we can lower this to 3 months of adjuvant chemotherapy to try to decrease the amount of neuropathy and decrease the amount of time that patients have to get chemo. And stay tuned, because we're going to be talking about this in our next episode, and we'll be doing a deep dive into the IDEA trial. So right now, you really either 3 or 6 months of adjuvant chemotherapy. Now, talking about surveillance, so once you're done with your adjuvant chemotherapy, how often are we seeing these people and, keeping track of if they recur or not? So the most important thing is that you want to make sure that you get a colonoscopy at 1 year after their surgery. And even more importantly, if a patient presented with a completely obstructing tumor and you didn't see the full colon at the time of diagnosis, you want to make sure that you get another colonoscopy as soon as you can to make sure that you're not missing any other second primary colon cancer. In terms of imaging, there's several different guidelines from many different groups, ASCO, ESMO, NCCN. The NCCN guidelines suggest a yearly CT chest, abdomen, pelvis with contrast for the first 5 years after diagnosis. In addition, they recommend checking CEA for every 3 to 6 months for 2 years, then every 6 months for a total of 5 years. And same thing with a history and physical exam. So after 5 years, there's really no need for oncology follow-up, obviously, unless there's something concerning or something new on physical exam.
Most recurrences occur in the first 3 years, and very, very few occur after 5 years. These surveillance guidelines are usually for patients who are at high risk for disease recurrence to begin with, so either our stage 2 or stage 3, not so much our stage 1, and there's uncertainty over the low risk stage 2 disease.
Yeah, stage 1 you really only need just colonoscopies periodically. There's really no need for any imaging or checking CEA levels after surgery.
So we hope this was helpful. So we hope this was a helpful overview on the approach to adjuvant management in colon cancer. As we'll be discussing in the breast cancer topics, adjuvant discussions can be some of the hardest discussions we have with our patients. They'll often come to you and their surgeon tells them that they, quote, got it all, and then the patient arrives in our room and we're trying to convince them to take toxic poison for the next 6 months of their life that could lead to lifelong complications. I think having a good grasp on the risk of recurrence based on their presenting features, utilizing the data we've discussed here, as well as many clinical tools and databases that are available online, such as the ESMO colon cancer recurrence database, can help you be prepared and let the patients know what level of benefit you're offering, what cost this will be to the patient in terms of treatment toxicity. So
bottom line, there is pretty good evidence for adjuvant chemotherapy for anyone with stage 3 disease. So that's anybody with lymph node involvement. A 30% reduction of disease recurrence or death with 5-FU alone, and an additional 20% on top of that with oxaliplatin, I think is a significant improvement. We're taking people who had a 50% risk of dying within 5 years from metastatic colon cancer and reducing that to something closer to 70 or maybe even 80% as we look at the long-term outcomes in the IDEA trial. For stage 2 disease, there is less convincing data. However, there have been some subgroups that we think chemotherapy will reduce the recurrence risk. So surely anyone with a T4 tumor, inadequate sampling of lymph nodes, so less than 12 lymph nodes, perforation obstruction, perineural invasion, lymphovascular invasion, or anybody with positive margins are things you want to consider when discussing adjuvant chemotherapy with your stage 2 patients.
Speak to those who specialize in colon cancer, wherever you may be training, and get their input on certain factors that may help them sway one way or the other between observation.
And then stay tuned for our next episode where we talk about the duration of adjuvant chemotherapy, 3 versus 6 months in the landmark IDEA trial.
Yeah, I think this will be a good discussion. I think there's a lot of emerging opinions on some of the outcomes of this trial, and it's one of the areas of cancer where we're seeing the approach actively evolving. Thank you so much for listening. We hope that this is helpful.
Thanks for listening. See you guys next episode. I guess we won't see you.
Hope to have you hear us next time.
For more information, follow us on Twitter at Talking Tumors, or feel free to email us at talkingabouttumors@gmail.com.
Please rate and review the podcast. We really appreciate it.
And special shout out to our friend John Kim for all of his musical talents.
And he is the composer of the music that you're hearing right now. Talking About Tumors is not medical advice.
For medical advice, please contact your own healthcare provider.
Opinions stated on this podcast are by the Ryan who said it and no one else. We have no financial disclosures, and this is done purely on our own time to the sake of our enjoyment of the field of medical oncology. Thank you for listening, and see you next time.